I'm Matt Thompson, CEO of Endologics. I'm delighted today to be joined by Dr. Kyle Reynolds, Dr. Nelson Bernardo, and we're going to talk a little bit about the introduction of a new therapy, percutaneous transmural arterial bypass, or PTAB. Both Dr. Reynolds and Dr. Bernardo recently authored an article for Endovascular Today, revascularizing complex SFA lesions and CTOs. Is it PTAB with the detour system time? So, gentlemen, thank you very much for authoring that article. Let me, I suppose, kind of kick off with a basic question. The detour system is really predicated on treating long, complex SFA lesions. So maybe I could ask both of you to start with by talking a little bit about the strengths and the weaknesses of the current treatment options, both endovascular and open surgery, that are available for Task D lesions of the SFA, and then we'll kind of get into where you see detour in your practice. So Kyle, maybe you start, and then Nelson.
Yeah, sure. Kyle, go ahead.
Yeah, of course. Coming off of Best CLI and Basal was two simple but not so easy questions that we're still working on seeing, right? So we know with these long lesions and all the good things that we got from that data, that unfortunately 15 to 20% of the patients that are CLI patients just necessarily don't have good outcomes, don't do well. The morbidity and mortality is still high. And with endovascular, there are benefits of not having to have these incisions, decrease hospital stays, decrease risk of infection. But unfortunately, that also comes with a higher risk of re-interventions. So when you get to these long calcified lesions, even with vessel prep, you don't always have the best patency. And sometimes you still kind of need these endovascular options. So, looking at the patient, kind of seeing what their comorbidities and what their vasculature is and what their outflow targets are, and again, what their conduit is. Sometimes there's benefits, sometimes there's not for endo versus open.
Nelson, thoughts?
Yeah, sure. So coming from the endovascular side of things, right? So we know very well that in our sort of endovascular percutaneously, we get, I would say, if you look at the data, good results with stenting is less than 150. I always give that to our fellows. So we're always in a dilemma when we're treating a long CTOs, and typically we get referrals for CTOs and SFA. They're talking about 200, 300 cm of CTOs. And we all know very well that in the current sort of technology available, stenting is not the solution to the problem. Some people would argue, hey, maybe you can use EPTFA covered stent like a Viaman, which has good data with long lesions. But unfortunately, you are faced with sort of what I call complication that could happen very rarely, but very catastrophic. So some of us shy away from using that. And of course, basically right now, in my practice, what I've been doing is just basically using drug-coated balloon and hoping for a better result compared to just plain old balloon angioplasty. But so there's really an unmet need in patients with long lesions. Now, to complicate matter more, right, is when you deal with long CTOs that are very complex, heavily calcified. And we know very well that with the current technology, we don't get very, very good result, even with all the atherectomy devices we have, or stents that are supposed to have good radial forces. So really, there's a need in this subgroup of patients with long CTOs that are complex.
Okay, so Nelson, you were involved in the Detour 2 IDE trial. That was the trial that was run that eventually led to FDA approval of the Detour system. It had breakthrough device designation. Can you maybe just talk a little bit about how you got involved in that trial and what attracted you to it? Because obviously, Jim Joy's been working for many years on developing this therapy and, finally got to commercialization. So how did you get involved?
So in the endovascular world, sort of, Matt, I've been dealing with a lot of CTOs. That seems to be my sort of, I don't say area of expertise, but do a lot of CTOs, especially long CTOs. And so, I would say for the past, exact 20 years of my practice, it's been looking for solutions, so looking for things to do to improve outcome for our patients with long CTOs, right? And so, in the world of endovascular intervention, we talk, we get involved, and that's how I got into sort of Jim Choi and then Hauser, who was involved in it, and that's how I got invited to be part of it. Because I do a lot of CTOs, and then I have the patient population of having CTOs of more than 150, 200, 250 in length, so it was easy for us to get patients for the study, basically, and that's how it got started.
Yeah, so that study was clearly pivotal for us in terms of getting an approval of the device. So the patency rate was good, the technical success rate was good. The device is now approved. So Kyle, you're obviously going to be one of the early adopters alongside with Nelson. How are you going to go about defining which patients in both of your practices are you going to select for the detour system at the start of your practice, and then maybe talk a little bit about how you see the therapy evolving and whether you're going to use it in a wider population? So how are you thinking about starting, and then how do you go from there?
Yeah, so starting out, what I see is another tool in my toolbox to be able to help take care of patients, because unfortunately, as great as the data is for this, and as great as the data can be for a lot of these pivotal trial studies, nothing lasts forever. And that's what we always see. And the patients usually have to come back, unless, it's for limb salvage. But a lot of times, similar to Dr. Bernardo, it's a lot of CTO patients that have rest pain, and, they keep coming back once their things go down. So for a lot of these long segment lesions, for me, it's another option. Similar to Dr. Bernardo, I tend to, try and vessel prep and use the DCB first if I can get a good enough outcome. And again, secondary stent if I have to. But for a lot of patients where the long lesions, the stent fails, I still have that option because I can use this and not necessarily have to go straight to bypass. So if patients come in that are already stented, they have in-stent restenosis, the stents that are occluded, these are good candidates where I think they will have to go. Again, also if there are long SFA lesions where, we see that sometimes we don't always cross. And if you have that failure, that technical failure, this is an option that you can have before bypass, especially in patients that don't have a good vein conduit. Now, there are going to be times where I still will use a vein conduit first for a bypass. But when you're starting to look at PTFE, especially in my practice here in DC, where a lot of the patients, they can even have transitional housing. So I might be worried about infection risk if they don't even know where they're going to stay when they get out. A lot of single mothers or patients that have to worry about childcare, and they can't afford to miss time, and it delays their care. This gives me another option when they're really, not wanting to go forward with a bypass, and they're being told that they're non-compliant or they're leaving AMA, but if they really have other things going on in this life, this gives us another option to be able to get the patient home, help take care of their immediate problems while they adjust what's going on in their life.
Great, thanks. Nelson, any thoughts on that, on who are you going to start with and then how you see it evolving?
Sure. I think I've talked to Kyle about this. So the way I look at it right now, as in our practice, right? So if you've got a long CTO, let's just talk about the CTO. This is a group of patients we're going to be dealing with. So a very complex calcified, and I know very well that endovascular treatment most probably will not give me a long-term patency, right? So your only option would be, hey, Kyle, can you do a FEMPOP bypass using a vein, of course, not PTFE. So if that's not an option, and I know I'm not burning the bridge for a secondary, let's say, surgical revascularization, then that would be the group of patients that I'm going to basically offer PTAB as a first option. But if it's just a regular long CTO, I'll be honest with you, I would say, hey, try to recanalize. Maybe I use my DCB. Let's give you 6 months, 9 months, 12 months, or 2 years of patency if I can achieve that. Then that restenosis, then most probably PTAB would be the way to go. Instead of, some people would say, hey, after that, maybe try stenting. But again, if you stent 250 to 300 cm of SFA, most probably you're just going to be dealing with restenosis. So I think after that first failure, then I would go for the PTAB, or if Kyle, right, we can go for a FEMPAP bypass using a vein graft. If the FEMPAP bypass is using a PTFE, I think I'll go for PTAB over that. What do you think about that statement, Kyle? FEMPAP bypass, not vein, go for PTAB rather than an EPTFE graft.
I think when it's not vein, then it becomes a lot more of a desirable option if the patient doesn't have adequate vein than using it before PTFE, because PTFE infections are some of the worst things that we have to deal with in vascular surgery, as we know. And again, sometimes if someone has a FEM PTFE bypass and me and Nelson are like, you know what, we can recanalize the native, or hey, this bypass is down, but we still have room to be able to do this. There are failed bypasses that we think we'll be able to go back and use this as well.
Yeah. So when I go to the critical limb ischemia meetings and I hear all you eminent people talking, everyone gives their own algorithm for treatment of long SFA disease, and no one has the same algorithm. So some people are surgery first, some people are endo first. We've seen the two big multi-center trials report. We've got innumerable options. As you're all aware, there's been a lot in the press about atherectomy recently. So whole host of different treatments. No one has the same. If you were to think about your SFA algorithm today, and you've spoken a little bit about where you're going to start to adopt detour, how do you think that algorithm changes with more experience of PTAB and the detour therapy? Does that eventually rise to kind of first line treatment? And what would you guys need to see in terms of clinical practice, ease of the procedure, evidence? What would you need to see to move that treatment up your algorithm?
I was going to say, for me, I think it's going to take, actually having the results in those patients, which, me and Nelson have our list that are starting to come soon. Because again, where I still will go back after a failed maybe atherectomy DCB, or I would say IVL DCB, and go ahead and try with a drug-eluting stent. Nelson saying, okay, maybe I know that these, long 300 lesions aren't going to last, which again, we know I'm hoping for a year, maybe, in this aspect to, if we can see that we're just going to get such a much better result, especially with the long-term data for PTAB, we start looking at 5-year data and seeing that, or just us from our personal experience with patients, I think it starts bumping up my algorithm to even catching up to Nelson's from the endo side.
So Matt, I think it will take, this is like stenting in the SFA.
Yeah.
I always tell our fellows and, patients, I said, if we can have a stent like what I do in a coronary stent, it's not an issue, right? I put stent in a coronary bed right now. I don't even think about restenosis, right? Because it's sort of a single digit and, nothing. But in the SFA, it's a lot of thinking that goes through before I do a certain procedure, because I have to always weigh the pros and the cons, right? Okay, I put a stent in. In 6 months, it can be closed down. So why do I even bother putting it right now, right? Or I would say, okay, why don't I just balloon it, DCB it? Then if it restenosis maybe focal, then I just end up with focal stenting, right? And I say, okay, if I have put a stent of 100 or 80 or 60, then my patency would be a lot longer. So this is where PTAB would come in, when you can show us data that say, hey, you put a PTAB in and I'll give you a patency, maybe like 3 to 5 years of good outcome. Then I said, okay, then it's as good as doing a bypass then, and then why not, right? And especially like Kyle was mentioning a while ago, it's you put a PTAB today, and maybe actually the same day you can send a patient home. So you change that what the prolonged hospital stay that Kyle was worried about in some group of patients that we have. So I think we have to have that kind of data before I would say it would change everybody's algorithm to basically proceed with PTAB right away in long SF lesions. What do you think about that, Kyle? You agree with that statement, or is
I
that
agree.
is that a fantasy that I'm
I
hoping
mean,
for?
I think that's our dream. That's, you know, vascular surgeon interventional's dream. That's probably endologic's dream with this technology, is to, you know, get that bypass patency, but then have to decrease interventions that you need, right? So if you're not having as many re-interventions that you normally would with the technology that we have available now, but you're getting that good 3 to 5 year patency rates equivalent to maybe a bypass, then yeah, that bumps up my algorithm for sure.
Okay, so I mean, obviously we're just in the early stages of launching the therapy. We'll obviously take feedback on the devices, the procedure. We're likely to make newer iterations of things that you guys identify as being needed, but we obviously have to run some studies as well. We'll be in post-market registries to make sure that the outcomes are what we think they're going to be. So if you were to think about some of the kind of key research questions that we should design the post-market studies to answer, can you maybe expand on that a little bit? Obviously, we've got a bypass graft going, you know, through the venous system for the first time. There's obviously going to be some questions about DVT, chronic venous insufficiency. So maybe both of you just expand on some of the research questions that are at the forefront of your mind that we need to design the studies to answer.
Yeah, sure. Matt, I think for me, it's very, very simple, really. So like I pointed out a while ago, right? Patency.
Yep.
So with this device, my concern would be my inflow, outflow, right? I mean to say my inflow and outflow. So one thing that we can do is, do I put some DCB technology in the inflow, outflow to prevent this from happening, right? Or like when I did do my below the knee issues, is do I put a drug-eluting stent on the inflow, outflow to take this problem out of the equation? Then the second question would be for patency again is there any role for NOAC, like apixaban, rivaroxaban, in terms of giving you longer patency for your EPTFE graft, right? So I guess when we start doing this, then it will be time for us to start collecting data in the sense that, okay, I did 10 patients, let's say 3 of them restenosis. Was the restenosis or occlusion happen at the inflow, the outflow, or is it the whole graft? So those are very simple questions, but I think would definitely change I call definitive management of these patients, because that would definitely, let's say, if I can show that a drug-eluting stent or a DCB improves the patency of the inflow, then hey, maybe we should do that as adjunctive therapy. Yeah. And then, of course, the anticoagulation therapy is also a question that we need to basically answer. Hey, Kyle?
For me, I definitely think anticoagulation is something that we're going to add on, because Matt, you touched on it. One of my biggest concerns to add on is going to be about the venous system, right? I know in initial trials, the rates of DVT were extremely low, but I'm thinking, you know, if that stent is in there for how long, what are the rates of DVT? If we say they're not clinically significant, how are we saying that? Are we checking Villalta scores? Are we seeing with the quality of life what's actually happened with the venous insufficiency, or not insufficiency, but just it seems like from a physiological standpoint, it would cause some type of obstruction. So I was glad that the rates of DVT were really low, but to really look at that long term and see what's happening and what we can do to prevent any problems is going to be key.
Yeah. Then on that note, then Matt, then you could always, you know, a study of a low dose or regular dose NOACs, right? Low dose rivaroxaban or high dose rivaroxaban, because, you know, basically say low dose complication rates is a lot lower, but if it doesn't prevent the DVT that Kyle wants to see, then we should use the higher dose of the NOAC agent. You know, again, some data that we can collect and will give us an answer for this.
Yeah, it's certainly we need to define the long-term venous outcomes. I mean, as Kyle said, the DVT rate in the trial was low, but that's out to 2 to 3 years. That isn't 4 to 5 years, and see how the legs do. Let me ask you guys about your practice. So you're reasonably unusual in that there's vascular surgery and interventional cardiology kind of working together to innovate and introduce a new therapy. How do you see the future of critical limb ischemia treatment? Is kind of multidisciplinary approaches, multidisciplinary teams the way to go? Is that the future, and is that what you're driving to in your hospital system?
Yeah, Kyle, you want to go?
I was going to say, I 100% think that's the key. And when you look at any review article, anyone that's having a discussion about best CLI and basal, and that's kind of what the conversations are, right? Seeing the importance of that interdisciplinary approach. Matter of fact, USC was one of the highest enrolling centers for best CLI. And that was, Dr. Rowe gave a great conversation about how he didn't do as many tibial interventions before, but they had a great collaborative approach with their bypasses and their more complex endovascular, because at some institutions, where vascular surgeons can do everything, you do have interventional cardiologists and interventional radiologists that do a little bit more different things and approaches and accesses and technologies for some of these more complex diseases where they're using endovascular. So having those options, and it's no longer just, okay, I can only do endo, so I'm going to do endo with Mia Nelson because, the bypass option is there, but also pushing the endovascular envelope a little bit just to try and do what we can, what we think is best for patients and, patients' preferences and scenarios, treating everyone. I think the multidisciplinary approach is great that we've been using.
Yeah.
Hey, Kyle, don't forget our podiatrists and plastic surgery. I mean, they are very, very helpful. I mean, they are basically,
we all work together.
Yeah.
Our offices are next to each other. We talk to each other all the time about patients. It's like group chats about the patient. So
actually, it's very easy. We're lucky here, Matt, because we had a very strong podiatry service by the Georgetown plastic surgery practice. So easy. We just text each other, then we get to see the patient do it, and then we schedule procedure, whatever. It's just very, very, and I think that's the future of what we do. And actually, even for best CLI, Kyle, I think you were still a fellow at the time when I was enrolling all this BSL. It was easy. You just call Cam. You did a bypass on this one and just do the bypass, right? So I think the future, and I think Kyle knows, right? We run a pretty good vascular program in the DC area because cardiology, IR, and vascular surgery. We meet every 2 months. Every 2 months and talk about things both in the vascular world or radiology world or in coronary world. So I think it's very, very important. Success of any, I would say, CLI program is integration of vascular surgery, IR, cardiology, and podiatry service, and even plastic surgery service.
Yeah. So to that extent, how are the two of you going to kind of collaborate in terms of introducing Detour and doing your first cases? Because I know, Nelson, you've done some in the trial. Are you planning on sort of joint scrubbing to start with, or are you just going to get your individual experiences and then compare? There's obviously a ton of different ways to do it. So interested in how you're planning.
No, actually, we're doing our first 2 cases as joint, right? We're gonna.
I think we're doing the first 5.
Yeah. That's what we plan.
But even after that, I think we said 5.
Yeah, first 5 we'll do it together. Then we collaborate, and then Kyle will be doing a lot in Montgomery, though. Kyle, right? You'll be doing most of them in Montgomery. Yeah.
I'll do in Montgomery, but I also have fellows like Nelson does. But he has one of his good partners, Dr. You probably know as well, Dr. Galino, who's there as well, and we'll probably collaborate, seeing how it goes, because it seems like a 2-physician thing actually is the best with this procedure. So,
agree.
And from what you've seen of the procedure so far, and just going slightly off script here, what's the difficult steps of the procedure in terms of, you've been through training, Nelson, you did some cases in the trial. What's the kind of key critical technical aspect of the procedure that defines success or failure?
For me, right now I do a lot of the below the knee deep vein revascularization, right? So from what I remember for the Detour, it's the re-entry from the vein to the artery.
Yeah. Yeah, that makes
That's
sense.
the most difficult step that we're gonna face. The other, the SFA to femoral vein, that's easy, right?
Yeah.
It's the vein to the popliteal artery.
Yeah.
And I don't know. I've been. I think I told Kyle during the meeting. I said we just have to find a way, in terms of the markers, maybe, or how you sort of. Okay, that's the art. We just have to find our own technique to do this. Remember, Kyle, we talked about this.
Printing out the picture and hanging it up right there, so we know which
Yes.
way we're lining it up for
Okay.
the hieroglyphics.
Yeah, that makes sense. It's kind of interesting. I think we're up to about 25 first commercial cases now. The sort of mean time in the trial was about 3 hours for the procedure, but actually we're well below that in commercial cases. So it seems that some of the technical aspects in terms of how you'd superimpose the vessels were worked out in the trial. So we're hoping you guys get nice, straightforward, quick cases.
We will.
But guys, thanks for coming on. I know you've had to squeeze it into, busy practices, conferences, the rest of it. So very much appreciated.
Of course. Thanks for having us.
Sure. So
Thank you.
Thank you so much for that interview and your thoughts. I'm really looking forward to seeing you do your first cases and hearing about how the practice evolves and how you can incorporate this system into your algorithm for the treatment of patients. So once again, Nelson, Kyle, thank you so much for your time. Very much appreciated.